Hello, everyone, and welcome to today's webinar, Quantitation of Free Light Chains in Serum and the Need for Standardization. I'm Susie Valdez of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Binding Site. To learn more, visit them at us.bindingsite.com. Now, we encourage you to participate today by submitting as many questions as you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have any trouble seeing or hearing this presentation. I'd like to now welcome our speaker, Dr. Kaz Murata, an Associate Attending Clinical Chemist at the Department of Laboratory Medicine at Memorial Sloan Kettering Cancer Center. Dr. Murata, welcome. You may now begin your presentation, sir.
Thank you very much for the kind introduction. So as you mentioned before, my name is Kaz Murata, and I currently work at the Memorial Sloan Kettering Cancer Center. And I will be speaking today on the quantitation of free light chains in serum and the need for standardization. The learning objectives of this talk are threefold. One, to describe the serum free light chain assay and its role in the screening, diagnosis, and monitoring of patients with monoclonal gammopathies. Two, to list the different methods by which free light chains are quantitated. And three, to identify issues which should be considered when switching free light chain assays. I'd first like to start with a very brief introduction to multiple myeloma, as that is the disease which is the most relevant to the quantitation of free light chains. Multiple myeloma is the uncontrolled growth of a single growth of plasma cells producing a single immunoglobulin. This clone of plasma cells proliferates in the bone marrow and may cause extensive skeletal destruction. This skeletal destruction is responsible for osteolytic lesions, osteopenia or thinning of the bone, and/or pathologic fractures. To put quite simply, multiple myeloma is a cancer of the plasma cells. So what exactly are plasma cells and what exactly do they do? Plasma cells are mature B cells or B lymphocytes. Once B cells fully differentiate, they tend to reside in the bone marrow as well as lymph nodes. Plasma cells are responsible for synthesizing immunoglobulins, which play an important role in protecting the body from infections. Most importantly, however, once these plasma cells have performed their function and cleared their infection they have been fighting, these cells are programmed to die off. An abnormality in this process may result in plasma cell disorders, one of which is multiple myeloma. The pathophysiology of multiple myeloma is quite complex, and I will not be going into that deeply here. However, at its basic level, the cancerous plasma cells cause damage to multiple organs due to the overgrowth of neoplastic plasma cells, as well as the overproduction of immunoglobulins and immunoglobulin byproducts, which we will discuss in more detail later. The clinical course of multiple myeloma is highly variable. Although it is generally not a disease which is curable, it is highly treatable. Left untreated, the average survival may be approximately 6 months. Fortunately, there have been many recent advances in the treatment of this disease. This has resulted in significantly improved survival times and quality of life for the many treated patients. Multiple myeloma is typically treated with one or more treatment modalities, depending on prognostic factors as well as response to treatment. Treatments typically consist of chemotherapy, autologous hematopoietic stem cell transplantation, or more recently, targeted therapies, such as anti-CD38 monoclonal antibodies, including daratumumab, or proteasome inhibitors, such as bortezomib. An important aspect of treating multiple myeloma is the need for monitoring following therapy. I mentioned before that multiple myeloma is generally not a curable disease, and patients will inevitably relapse following any form of treatment. This may occur as soon as a few months, while some may not relapse for years. Once relapse occurs, patients may need to undergo another round of treatment and in many cases require a change in the treatment regimen. Fortunately, given the availability of a range of therapeutic options, patients can undergo treatment following multiple relapses, allowing for longer survival. This improved survival, however, is only possible due to constant monitoring of disease to detect relapse of disease. Laboratory testing plays a key role in the management of myeloma patients due to its ability to detect relapses. In addition to many common laboratory tests, such as basic and comprehensive metabolic panels, which can detect abnormalities in vital organs such as the liver and kidneys, certain specific laboratory tests are used in the monitoring of patients with multiple myeloma and other monoclonal gammopathies. One such test is the serum protein electrophoresis. Serum protein electrophoresis is the electrophoretic separation of the major proteins dissolved in serum and is capable of quantitating the M protein generated by the myeloma plasma cells. Generally, the size of the M spike is one measure of the tumor burden in myeloma patients. Other key tests used in the diagnosis and monitoring of multiple myeloma include urine protein electrophoresis and the serum free light chain assay. The important thing about these two different assays is that they both essentially measure the same thing, which is the quantity of free light chains in patients with multiple myeloma. So what exactly are free light chains? In order to understand exactly what free light chains are, it is first important to understand the structure of the immunoglobulin molecule. Immunoglobulins are essentially the life work of the plasma cell and are large Y-shaped proteins made by differentiated plasma cells to identify and neutralize foreign objects. Also referred to as antibodies, these proteins are highly specific and are custom made by plasma cells following exposure to infections. Once made by the plasma cell, these antibodies have the ability to bind foreign organisms and substances. They can lyse bacteria through the activation of the complement cascade, neutralize viruses by blocking cell receptors used by viruses to invade cells, and activate other immune effector cells such as macrophages. They essentially serve to clear up infections or other foreign material from the body. On this slide is a picture of an immunoglobulin molecule. The important thing to understand here is that these immunoglobulin molecules have a modular structure. The modules in this particular case are light chains and heavy chains. And in the case of immunoglobulin G, the most common immunoglobulin in the body, is comprised of 2 heavy chains and 2 light chains. I mentioned in a previous slide that free light chains are important in monitoring myeloma patients. The term free light chains refers to light chains that are not bound to heavy chains, as is found in normal, intact immunoglobulin molecules. In healthy individuals, light chains are generally only found in the serum already bound to other heavy chains in the form of intact immunoglobulin molecules, and free light chains are present only in minuscule quantities. In the case of myeloma, however, the cancerous plasma cell clone, being highly dysfunctional, produces an excess of light chains, not all of which may be bound to heavy chains. Other situations in which free light chains may be elevated include inflammatory conditions such as autoimmune disease, infections, as well as bone marrow transplants. Finally, it should also be noted that light chains come in 2 forms, kappa and lambda. So why exactly is the measurement of free light chains important in myeloma patients? I mentioned previously that the M spike, which is the quantitation of the total amount of intact monoclonal immunoglobulin produced by the cancerous plasma cell clone, also serves as an indirect measure of the tumor burden. Free light chains are essentially a byproduct of the M proteins produced by the myeloma cells. Much like a dysfunctional car factory producing way too many steering wheels for the number of whole intact automobiles manufactured, myeloma cells can often generate high amounts of free light chains in addition to high amounts of intact monoclonal immunoglobulins. A key thing to know about free light chains is that elevated concentrations over a prolonged period can have detrimental effects on the kidneys due to the clogging of the renal tubules. It is for this reason that myeloma patients tend to develop renal failure as the disease progresses. Higher concentrations of free light chains in myeloma patients have also been correlated with a poorer prognosis. Finally, another important thing to note about free light chains in myeloma patients is that approximately 16% of myeloma patients have what is referred to as free light chain myeloma. This is a situation in which the myeloma cells have lost the ability to produce heavy chains to accompany the light chains being generated. In these cases, patients have high concentrations of monoclonal free light chains in their serum, and these free light chains essentially become the patient's M protein. Free light chains were not always measured in serum. In fact, they were first discovered in 1845 by Dr. William McIntyre of London in the urine of a 45-year-old grocer, Alexander McBean. The patient suffered from severe bone pain and fractures. Edema and nephrosis, or what we would typically refer to as nephropathy or kidney disease, was suspected. The patient's urine was tested for the presence of albumin, which indicates damage to the kidney. It was then that it was discovered that a protein precipitate formed in the urine upon warming, but then redissolved to 75 degrees Celsius. Dr. McIntyre then had the urine sent to Dr. Bence Jones, a chemical pathologist at St. George's Hospital, along with the following note. Dear Dr. Bence Jones, the tube contained urine of a very high specific gravity. When boiled, it becomes highly opaque. On the addition of nitric acid, it effervesces, assumes a reddish hue, and becomes quite clear. But as it cools, assumes the consistence and appearance which you see. Heat reliquefies it. What is it? Although the patient died 2 months later, Dr. Bence Jones seized this opportunity to publish his findings regarding this patient's mysterious urine in The Lancet, a British medical journal many of you may have heard of, in 1847. In this publication, Dr. Jones referred to the protein as a, quote, hydrated deutoxide of albumin, end quote, and noted its significance as a diagnostic marker for, quote, myelitis osseum, or multiple myeloma as we refer to it today. Although Dr. McIntyre did eventually get around to publishing his own description of the urine in 1850, it was Dr. Bence Jones who became rich and famous due to his publication, while Dr. McIntyre to this day is still relatively unknown. To this day, the presence of free light chains in urine is referred to as Bence-Jones proteinuria. A hyphen has for some reason been added between the Bence and Jones, and people are still unsure of when and how this occurred, as Dr. Bence Jones had no hyphen in his name. History aside, as of present, there are essentially 3 major methods of detecting the presence of free light chains in myeloma patients: urine protein electrophoresis, urine immunofixation electrophoresis, and serum immunoassays. Urine protein electrophoresis is one of the older methods of detecting and quantitating free light chains in urine. It indicates the presence or absence of a monoclonal protein in the urine in the form of an M spike. These M spikes can be quantitated, and the amount of free light chain excreted in the urine can be calculated based on the amount of total protein in the urine. The problem with this technique is that due to the variability of urine concentration with hydration status, this requires a 24-hour urine collection, which is cumbersome for the patient. In addition, this method alone cannot perfectly distinguish between an intact immunoglobulin M protein and an M spike caused solely by free light chains. This is because in most healthy individuals, immunoglobulin molecules are too large to pass through the glomerulus and do not appear in electrophoretic analysis of urine. However, in patients with myeloma, the kidneys suffer progressive damage over the course of many years due to the presence of free light chains. This results in the appearance of intact immunoglobulin M proteins in electrophoretic analysis of urine, along with M spikes caused by the presence of monoclonal free light chains. Urine immunofixation electrophoresis is essentially an extension of urine protein electrophoresis in that it involves the application of antisera to a serum to a urine that has been electrophoretically separated on an agarose gel. It is able to indicate the presence or absence of a monoclonal free light chain, as well as identify the type of free light chain, kappa or lambda. The key thing about urine immunofixation electrophoresis is that it is a qualitative assay and is not able to quantitate the amount of M protein in urine. It is, however, due to the fact that it is an immunoassay, more sensitive in its ability to detect free light chains in urine compared to a simple urine electrophoresis. Urine immunofixation, however, also has the same limitations that urine protein electrophoresis does, in that it also requires a 24-hour urine collection. It was actually not until the 21st century that a usable test for quantitating free light chains in serum came about. Although other assays for light chains did exist, they were not specific to free light chains. This created a problem as serum contains high concentrations of immunoglobulins, unlike urine, which is relatively free of immunoglobulins due to glomerular filtration. In 2001, immunoassays based on polyclonal antibodies were developed that were capable of measuring free light chains at concentrations present in serum were developed. The elevation of serum free light chains in this assay was found to be highly sensitive and specific for patients with Bence-Jones proteinuria. This assay will go on to be commercialized into a product known as Freelight. It should also be noted that this product was not only a huge commercial success, but it is also now incorporated into the International Myeloma Working Group guidelines for the diagnosis and management of patients with multiple myeloma. The Freelight assay is a nephelometric immunoassay. In this system, polyclonal antibodies against free light chains can clump together to form large immune complexes which cause the serum solution to become turbid. This results in increased light scatter through the serum solution and allows us to quantitate accurately and precisely the amount of free light chains present in serum. The Freelight assay is FDA approved and is now indicated and widely used for the following purposes: the diagnosis and monitoring of patients with non-secretory myeloma and oligosecretory myeloma, diagnosis and monitoring progress of patients with light chain myeloma and amyloidosis, predicting risk of progression in MGUS, smoldering multiple myeloma, and plasmacytoma, diagnosis, monitoring progress of patients, and prognosis of patients with intact immunoglobulin multiple myeloma. The serum free light chain assay also has the interesting characteristic of not only quantitating free kappa and free lambda light chains in serum, but also being able to identify the presence of a monoclonal gammopathy simply by the ratio of the kappa to lambda free light chains. It has been demonstrated thoroughly in large clinical studies that most healthy individuals have a kappa to lambda ratio of 0.26 to 1.65. It has also been shown that people whose kappa to lambda ratio fall outside the 0.26 to 1.65 range either have a monoclonal gammopathy or multiple myeloma. Furthermore, the kappa to lambda ratio has proven to also be useful in monitoring myeloma patients undergoing treatment. A normalization of the kappa to lambda ratio is generally considered a positive response to treatment. The International Myeloma Working Group, which develops guidelines related to the management of myeloma patients based on scientific evidence and expert consensus, issued guidelines and recommendations related to the use of the serum free light chain assay in multiple myeloma and related disorders in 2008. These include recommending the use of the serum free light chain assay for screening at diagnosis, as well as its use as a potential replacement for 24-hour urine electrophoresis and immunofixation in patients already diagnosed with light chain amyloidosis. Other guidelines include medical decision limits for serum free light chain quantitation and definitions of measurable disease. Specifically, an involved free light chain concentration of greater than 10 milligrams per deciliter is considered abnormal and part of the definition of measurable disease. The IMWG also incorporates serum-free light chains results into their uniform response criteria shown here to classify patient response to different therapies and clinical trials. In this classification scheme, published in 2006, serum-free light chain quantitation is included as part of the definition for partial response. More recently, in 2014, the IMWG revised its diagnostic criteria for multiple myeloma to include kappa-lambda ratio of greater than 100 as a myeloma-defining event. This again underscores the importance of free light chain quantitation and kappa to lambda ratios in the diagnosis and monitoring of multiple myeloma. As mentioned previously, urine protein electrophoresis and immunofixation remained the mainstay of detecting and quantifying light chains until the advent of serum-free light chain assays. Even after the arrival of free light from the binding site, there were no other alternatives available for a long time. However, as of this recording in 2021, there are a total of 4 assays available for the quantitation of serum-free light chains on the market. These include the free light from the binding site, Serolite from Sabia, and latex free light chain from Siemens, and the kappa and lambda assays from Diazyme. Of these 4, 3 are FDA approved. So this begs the question, are results from different free light chain assays interchangeable? In the next few minutes, I would like to share with you the results of a study that we conducted in our laboratory to answer the question of whether free light chain assay results are interchangeable with each other. In our particular study, we decided to compare the traditional gold standard for free light chain analysis, the free light assay from binding site, with the most recent addition to the market, the Diazyme assay. This assay quantitates kappa and lambda free light chains in serum and is compatible with many other automated immunoassay platforms found in clinical laboratories. This makes this kit highly attractive for space-limited laboratories such as ours. Our study design was as follows. First, we set up and validated the Diazyme assay on one of our Abbott Architect C8000s that we currently use in the clinical chemistry lab. We then compared the analytical performance of the Diazyme assay with free light in a set of 61 MSK patients, as well as a separate set of 127 presumed healthy serum donors. Our first study population consisted of waste serum specimens from 61 MSK patients who had serum protein electrophoresis, immunofixation, and free light testing performed in the clinical laboratory. Information available from these specimens included free kappa and free lambda values obtained from the OptiLight, the kappa to lambda ratio, serum or plasma creatinine levels, IgG, IgA, and IgM, and M-spike values obtained via serum protein electrophoresis, immunofixation results, as well as gender and age. This slide shows the distribution of monoclonal gammopathies among the 61 patients. These 61 patients were selected during the process of serum protein electrophoresis interpretation, and an active attempt was made to get an even distribution of patients with monoclonal IgG, IgA, IgM, and free light chain monoclonal gammopathies. After analysis of the 61 specimens using the Diazyme assay, it became apparent that the laboratory would be required to develop its own dilution protocol for the assay. 12 out of the 61 specimens could not be compared due to missing kappa or lambda values from the Diazyme assay. The missing values were due to an error output from the C8000. We believe that the error messages were likely due to kappa to lambda values or lambda values exceeding the analytical measurement range of the assay based on available data. We then analyzed the data from the remaining 49 specimens which did have both binding site and Diazyme results. Shown here is a method comparison plot between the binding site and Diazyme assays for both kappa and lambda, with the binding site or predicate assay on the x-axis and the Diazyme assay on the y-axis. The data shows significant negative proportional bias at high kappa and lambda concentrations. This is most likely due to the, quote, hook effect or antigen excess seen in the diazyme assay at high concentrations. This also illustrates the need for implementation of a robust manual dilution protocol for the diazyme assay. In addition to monitoring the quantity of free kappa or lambda light chains, another key feature of free light chain assays is the ability to monitor disease progression using the kappa to lambda ratio. For this reason, we compared the concordance of abnormal kappa to lambda light chain ratios. As many of you are aware, there's an established kappa to lambda ratio which is currently used by clinicians to monitor patients when using the free light assay. We applied both the 100% diagnostic range as well as the diazyme recommended kappa to lambda reference range to examine the concordance of specimens with normal and abnormal kappa to lambda ratios. We found in our study that 40 out of 49 patients were in agreement regarding the abnormal or normal light chain ratios. Of the 9 that were discordant, 8 were found to be normal by free light and abnormal by the diazyme assay, while 1 was found to be abnormal by free light and normal by the diazyme assay. The 2x2 table on the right shows a similar analysis, only this time using the diazyme suggested kappa to lambda ratio reference range to determine abnormality from results obtained using the diazyme assay. As you can see, the results are identical. This data indicates that the application of the 100% diagnostic range, or the diazyme suggested kappa to lambda ratio to results obtained from the diazyme assay, may potentially result in significant misinterpretation in the form of false positives. For the second part of our study, we took serum specimens from 127 presumed healthy donors and analyzed the specimens on both the binding site free light and the diazyme kappa lambda assay. As you can see from the method comparison plots, the comparisons show relatively high correlation within this range, with both correlation coefficients above 0.9. However, there is a positive proportional bias of approximately 15% in the kappa and a negative proportional bias of 20% in the lambda. There also appears to be a constant bias of approximately 0.3 milligrams per deciliter in the lambda. Another thing we wanted to examine in this study was the issue of reference ranges. Shown here are the reference ranges for free kappa, free lambda, and the kappa to lambda ratio established at the Mayo Clinic using free light reagents. Also shown is the 100% diagnostic range for the kappa lambda ratio, which has been shown to be indicative of the presence of a monoclonal gammopathy when a patient has a value outside the range. This range is currently used in clinical practice worldwide for the purposes of screening patients for monoclonal gammopathies, as well as managing myeloma patients. In this slide, we show the reference ranges we obtained for measuring 127 presumed healthy donors. Based on the central 95 percentile, we find that within our local population, the reference range using the binding site assay for free kappa is 0.84 to 2.7 milligrams per deciliter, and 0.75 to 2.52 milligrams per deciliter for free lambda. The reference range using the diazyme assay is 0.76 to 3.19 milligrams per deciliter for kappa, and 0.19 to 1.65 milligrams per deciliter for lambda. The reference ranges proposed by Diazyme in their package insert is 0.24 to 2.07 milligrams per deciliter for kappa and 0.42 to 2.77 milligrams per deciliter for lambda. This slide shows the comparison of the reference range for the kappa to lambda ratio obtained by taking the central 95% of the values obtained in the study. Based on this method, the values obtained from the free light method gave a range of 0.66 to 1.82, while the diazyme assay gave a range of 1.1 to 9.96. Another interesting thing to note is that the range of kappa lambda ratios for all 127 donors was 0.59 to 1.9 for the free light ratio, while the range using the diazyme assay gave a very wide range of 0.98 to 56.50. These high ratios will be considered highly abnormal and diagnostic of the presence of a monoclonal gammopathy if obtained using the binding site free light assay. Based on the widely accepted 100% diagnostic range for the kappa lambda ratio, we found that 9 of the 127 healthy donors will be classified as abnormal. If we applied the same criteria, i.e. the kappa-lambda ratio of 0.26 to 1.65 to the values obtained from the Diazyme assay, we find that 106 of the 127 donors will be classified as abnormal. In addition, we found that 102 out of 127 donors fell outside the reference range recommended for the kappa-lambda ratio by Diazyme, which is 0.22 to 1.74 when using the Diazyme assay. It should be noted that Diazyme currently does not provide a 100% diagnostic range for their assay. Thus, this is an unequal comparison comparing the number of patients falling outside a reference range using the Diazyme assay with the number of patients falling outside a diagnostic range. However, it is apparent that significant adjustments will have to be made by clinical staff in result interpretation when making a switch from binding site to Diazyme reagents. Our conclusions based on this preliminary study is as follows. Use of the Diazyme assay will require the laboratory to develop their own dilution protocols to analyze specimens with elevated kappa or lambda levels. This is particularly important as free light chains have a very wide dynamic range among patients with myeloma and other monoclonal gammopathies. Further dilution may be required even when the instrument gives a numerical result, as the resulting numbers may potentially be falsely low. Significant discrepancies can be noted in kappa and lambda quantitation, particularly at high concentrations. Significant discordance is seen in kappa-lambda ratios between the binding site and Diazyme assays, both in patients and healthy donors. And finally, any medical decision points based on kappa-lambda ratios will have to be redetermined in separate studies for the Diazyme assay. I would like to end this presentation with some short take-home messages based on our experience comparing the two free light chain assays. It is very important for laboratories to perform their own validation using clinical specimens prior to implementing a new free light chain assay. Also, free light chain assays as of present are not identical to each other, nor are they standardized. We believe that caution is warranted whenever a laboratory is considering a switch between free light chain assays. Thank you very much, and I'll be glad to take any questions at this time.
Thank you, Dr. Murata, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have any questions you'd like to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen, and we'll answer as many questions as we have time for. So let's take a look. We already have some great questions coming in. Dr. Murata, can you elaborate more on the conclusion point that says further dilution may be required even when instrument gives a numerical result, as the resulting number may potentially be falsely low? Does this mean there are issues with antigen excess?
Well, we believe that antigen excess is probably the most likely cause. We did not specifically, save the specimens to do further analysis because the way that we did this study, we essentially set up the instruments based on the instructions provided by the manufacturer, and the Abbott was the one who set up the assay for us. But essentially, if the instrument gave an error, we probably should have done a manual dilution to determine that it was antigen excess. But if we were to guess, it probably is going to be an antigen excess, as we did an analysis of we looked at the specimens that didn't give a numerical value, and that yielded a lot of high values for free light chains, especially for the lambda. So we do suspect that it might potentially be an antigen excess, yes.
And how did your findings compare to results from other Diazyme evaluations that have been published?
So as far as I'm aware, there may potentially be more by now. When I last did the literature search, there were 2 studies that have been published. One by Alan Wu at UCSF, and another, I believe, from Louisville. And they have both sort of shown that the assays are relatively comparable. But the one thing I want to add is that as a major cancer center, we did a fairly extensive evaluation of both healthy and patients with monoclonal gammopathies. And so we believe that it's a lot more thorough than what they did, which is just simply see if the values were relatively similar. We did an analysis including the ratios and the clinical significance. And one thing that's very important with the capital lambda analysis is the actual ratio. And so when you do these on patients and with healthy donors, you do end up, you kind of see where the issues are with the other assays. And so I think that we have shown a little bit, we kind of dug a little bit deeper, and we did find that there are some aspects where they're not entirely comparable. And so we do strongly recommend that people or laboratories do their own validations instead of in thorough evaluations, not just ones that are required from a CLIA point of view, but clinical evaluations on real patients to make sure that what they're getting, both for the quantitation and the ratios, are similar.
Thank you so much. And I want to thank our audience again for these great questions coming in. Our next question, an audience member says, more than 100 normal patients turned out to be abnormal when tested using the Diazyme test. This number seems high. Do you have any explanation or theory to explain this result?
Yeah, so one of the issues is that, remember, the reference ranges are different for the two assays. Now, the one thing that the binding site has going for it is that it has a lot of clinical studies behind it. As I showed in some of the previous slides, for the, let me just scroll back to this slide. Hold on. So this is a slide that I kind of wanted to show, actually. So the interpretation of serum-free light chain results, there have been quite a few large studies that show that kind of came up with this sort of 100% diagnostic range that shows that people who fall within this narrow range for capital lambda ratio are essentially do not have monoclonal gammopathies, whereas anybody that falls outside generally either have an MGUS or multiple myeloma. Now, with the other assay, with the Diazyme assay, they don't have a lot of the studies behind it. And so I think if people who want to use this assay really need to kind of, there needs to be another study, a larger study, to establish what that ratio is going to be for that particular assay. I know the Diazyme assay was FDA cleared using I believe the 501K equivalence mechanism, but it didn't undergo like as much of the sort of, it's not quite equivalent to the binding site. And so if people who want to use that assay are going to need to really just do their own study involving hundreds, thousands of normal and donors and patients to sort of establish a range that falls into the diagnostic area. And that's separate from the other potential antigen excess issues that we have encountered.
Thank you so much. And what platform was used to run the Freelight assay? Was it run on Abbott?
Actually, so the one thing about, so the plus and the minus of the Freelight assay is that, so the binding site actually controls specifically what instrument it's run on for. And there's actually probably, now that we've run it on the Abbott instruments, I think it kind of makes sense. If you're not careful with the binding site assay, you can end up with antigen excess as well too. And I published on this before, but those are relatively rare. And the reason why is because they actually do have an instrument called the, I'm blanking on the name. It's the, it used to be the binding site SPA, but now it's the OptiLite. And the OptiLite is actually programmed specifically to prevent the antigen excess. And so all the binding site assays are run on the Optilite, which is specifically programmed for running the binding site assays and also to prevent the antigen excess issues that could potentially be encountered.
Thank you so much, Dr. Murata. We have time for one more question. For error messages exceeding AMR, were they above or below AMR?
We believe that they were probably above the AMR. It's just that I think when you run the assay on these sort of other third-party manufacturers, sometimes it's because there's other, for example, when you run the free light on the Optilite, there are mechanisms in place to prevent, to detect the antigen excess. When you run assays on other platforms such as the Architect or other third-party instruments, there is no specific mechanism to detect it. So even though a result may be outside the AMR, the machine might potentially falsely detect it as within the AMR by antigen excess. And so we believe that the results that we got probably were outside the AMR. It just wasn't detected as being outside the AMR because it just didn't have the sort of safety mechanisms in place to prevent the machine from letting a result through without recognizing the potential antigen excess.
Dr. Murata, I want to thank you so much for your presentation today. Would you like to provide our audience with any closing remarks before we go?
Sure. As I mentioned in my closing slide, I think one of the things that's very important for labs or laboratorians is that when you do have an assay on the market, I think it's very important. The validation is important, not just from a regulatory viewpoint, but also from a patient care perspective. For those laboratories that do want to switch or are planning on switching, and this is not just for free light chain assays, but for any other assay, I think it's very important that they do consult with the clinicians. They inform the clinicians that they do plan on switching and that they do the switch in collaboration with them, because as we've seen in this particular example, you could end up with a situation where you have clinicians kind of confused with the interpretation of the results. And I think by working with the clinical staff in terms of when you do these switches, you tend to prevent any sort of future problems that may potentially occur as a result of an assay switch. And so I think it's very important for clinical labs to definitely do their own validation, both using clinical specimens as well as healthy donors, and also work with your clinical staff, the people who see the patients, so that there's no misunderstanding in terms of, when you do switch assays, that the clinicians don't notice, hey, we notice that there's an uptick in the number of abnormal patients. We don't know what's going on. So that's one thing that I would like to definitely put out to the laboratorians out there.
Dr. Murata, I want to thank you again for your time today, for your important research. And I want to also thank LabRoots and our sponsor, Binding Site, for underwriting today's educational webcast. And before we go, I want to thank our audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. And this webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. That's all for now, and thank you for joining us. Until next time, stay safe and stay healthy. Goodbye, everyone.